Welcome back to the deep dive. Today, we're really getting into something critical. We're navigating the world of the acute heart crisis.
Yeah, it's a complex area, and when things go wrong with the heart, acutely, I mean, decisions made in minutes, sometimes even seconds, can really dictate everything that follows.
Absolutely. The stakes are just incredibly high. So our mission today is to take all this clinical knowledge, this data you've pulled together, and really condense it. We want to give you, the listener, a really solid, high-yield grasp of coronary artery disease, or CAD, and acute coronary syndromes, ACS.
That's the plan. We'll cover rapid diagnosis, those critical management choices, and then dig into the complications that can pop up afterwards, really mastering the nuances.
Okay, so let's start at the beginning. Ground zero, really. Coronary artery disease, CAD. This is that slow, kind of sneaky process, right? Plaque building up over time,
Exactly. Atherosclerosis, it narrows the coronary arteries, the heart's own fuel lines.
leading to impaired myocardial perfusion. Basically, the heart muscle isn't getting enough blood, especially when it's working hard, like under stress.
Precisely. And when we're dealing with stable CAD, so the person feels okay at rest but gets symptoms with exertion, we need a way to see that supply-demand mismatch, non-invasively, ideally.
And that brings us to the nuclear stress test, using that technetium tracer.
Right. The technetium TC99 meter tracer lets us visualize blood flow. We get pictures at rest, and then again under stress, either exercise or medication-induced stress.
And this test spits out two really crucial pieces of information, these defects, as they're called.
Yeah, two main patterns. The first one, and this is often the one that really requires action, is the reversible defect.
Reversible. Okay, what does that look like?
So at rest, the heart muscle picks up the tracer normally, it looks healthy. But then under stress, the uptake in a certain area drops off significantly.
So that drop is the clue, the warning light, as you said before we started recording.
Exactly. It signifies ischemia. It means there's a significant blockage obstructive CAD. The tissue is still alive, it's viable, but that artery is so narrow that when the heart needs more oxygen during stress, the blood flow just can't keep up. It's starving, but not dead yet.
That's the signal for intervention then.
Definitely. It tells us there's a problem we likely need to fix, usually with stenting or bypass.
Now contrast that with the other finding, the fixed defect.
The fixed defect, yeah, that tells a different story. Here, the tracer uptake is low both at rest and during stress. Meaning that part of the heart muscle isn't viable anymore. It's scar tissue, most likely from a previous heart attack, maybe one the patient didn't even realize they had. The damage is already done. There's no living tissue there to save with reperfusion.
Okay, so let's focus on that reversible defect, the active blockage causing ischemia. What's the immediate first-line medical therapy before we even talk about procedures?
Right. The best initial sort of core medical treatment is a two-pronged approach. You need an antiplatelet agent like aspirin.
Chewable aspirin, usually, for faster absorption in the acute setting.
Yes. Or just daily low dose for chronic stable CAD. Plus, critically, a high-intensity statin, something like atorvastatin or rosuvastatin.
And the statin isn't just about lowering cholesterol numbers here, is it?
Not at all. I mean, lowering LDL is good, but the major benefit here is plaque stabilization. High-intensity statins make that atherosclerotic plaque less inflamed, less likely to rupture and cause an acute event. It shores up the defenses.
We also need to be careful about what we don't do, right? Things that might increase the heart's workload.
Absolutely crucial point. In stable CAD, it's all about balancing supply and demand. So you definitely want to avoid things that jack up the myocardial oxygen demand unnecessarily, like certain stimulants or drugs that make the heart pump much harder against that fixed blockage. That just pushes things towards a crisis.
Got it. Okay, that sets the stage for stable disease. Now let's shift gears into the emergency. Acute coronary syndrome, ACS.
Right, the crisis itself. ACS is really a spectrum. It covers unstable angina, UA, non-ST elevation myocardial infarction, and STEMI, and the big one, ST elevation myocardial infarction, STEMI.
3 different labels, but what's the underlying event that triggers all of them?
It's the same initial catastrophe for all 3. Acute plaque rupture. That unstable plaque that cracks open exposes the fatty thrombogenic core inside.
And the body immediately tries to plug the hole.
Exactly. The coagulation cascade kicks into high gear and bam, you get a thrombus, a blood clot, forming right there in the coronary artery, blocking blood flow.
So if the cause is the same, this clot, what makes unstable angina different from an STEMI, this is where troponin comes in, right? That blood test.
That's the absolute key differentiator. Both UA and STEMI present with ischemic symptoms. You know, chest pain at rest, new onset pain, or pain that's getting rapidly worse. A crescendo pattern.
But the damage level is different.
Precisely. In unstable angina, the clot might be temporary, or maybe it doesn't fully block the artery, so there's ischemia, there are symptoms, but it wasn't bad enough or long enough to cause actual heart muscle cells to die. So the cardiac biomarker, troponin, stays normal.
Whereas in STEMI, by definition, means troponin is elevated.
Correct. And STEMI means non-ST elevation myocardial infarction. The infarction part means cell death occurred. The blockage was severe enough or lasted long enough to cause some necrosis, releasing troponin into the blood. There's measurable injury, even if the ECG doesn't show those big ST elevations yet.
Okay, that's a critical distinction. Normal trops in UA, elevated in STEMI. But interestingly, the initial treatment for both is pretty much the same. Why is that?
Because the immediate threat is the same for both. That clot getting bigger or causing more ischemia or maybe embolizing. So you hit it hard right away with aggressive medical therapy.
Which includes
Dual antiplatelet therapy. So aspirin plus a P2Y12 inhibitor like clopidogrel, ticagrelor, or prasugrel. You need anticoagulation, usually with heparin. Beta blockers to slow the heart rate and reduce oxygen demand. Nitrates for symptom relief and vasodilation. And, of course, a high-intensity statin started immediately.
So even though STEMI is technically worse because there's cell death, you throw the same initial kitchen sink at both UA and STEMI.
Pretty much, yeah. You're trying to stabilize the situation, prevent worsening, while you figure out the next steps, like maybe an angiogram.
But there's one major therapy that's a definite no-go for UA and STEMI.
Absolutely critical point, fibrinolysis. Clot-busting drugs like TPA, alteplase, tenecteplase, these are not used for non-ST elevation ACS.
Why not? If there's a clot.
Because the clot isn't causing a complete full-thickness blockage across the entire heart wall muscle in UA and STEMI. Using potent fibrinolytics in that situation doesn't provide enough benefit to outweigh the significant risk of bleeding, including potentially fatal brain hemorrhage. You reserve those big guns for when the artery is totally occluded.
Which brings us squarely to the STEMI. The ST elevation myocardial infarction.
The STEMI, yeah, this is the big one. Complete or near complete occlusion of a major coronary artery. It causes transmural ischemia. The entire thickness of the heart wall in that area is dying.
And the diagnosis is immediate, based on symptoms and the ECG showing those characteristic ST segment elevations.
Yes. Classic chest pain presentation plus ST elevation in 2 or more adjacent ECG leads. That's a STEMI until proven otherwise.
And this is where that don't wait rule is paramount. You absolutely cannot delay things waiting for blood tests.
Cannot emphasize this enough. If the clinical picture and the ECG screams STEMI, you act now. Waiting for troponin results, which take time to rise anyway, is just condemning heart muscle to die unnecessarily. The single most important factor for long-term survival and preventing heart failure after a STEMI is getting that blocked artery open ASAP. Prompt reperfusion.
Okay, reperfusion. Getting the blood flowing again. What are the targets? The time goals.
The gold standard is percutaneous coronary intervention PCI, angioplasty and stenting. If the patient arrives at a hospital that can do PCI.
A PCI-capable facility.
Right. The goal is door-to-balloon time, from arrival at the hospital door to inflating the balloon in the blocked artery of less than 90 minutes. It's a huge systems of care challenge. Requires incredible coordination.
But what if they're not at one of those centers? Maybe a rural hospital?
Good question. If you can't get the patient to a PCI lab and have the balloon inflated within 120 minutes of first medical contact, so from when the paramedics arrived, for example, then fibrinolysis becomes the treatment of choice.
So clot busters are okay for STEMI if PCI isn't fast enough?
Yes, but only if PCI isn't readily available within that 120-minute window and the patient's symptoms started within the last 12 hours. There are also contraindications to fibrinolysis like recent surgery, stroke, bleeding disorders that you have to screen for carefully.
Before you get to the definitive reperfusion, PCI or lysis, what are the immediate stabilization steps, MO&A?
MO&A is the classic mnemonic, but it's expanded a bit. Oxygen if they're hypoxic, so saturation below 90%. Nitrates, usually sublingual or IV, for chest pain and vasodilation, unless you suspect that RV infarct we'll talk about. Aspirin, chewable, 325 milligrams, usually, right away. And morphine if nitrates don't control the pain.
But there's more now, right? The antiplatelets and anticoagulation.
Absolutely. You add a P2Y12 inhibitor load immediately, along with the aspirin, and you start anticoagulation heparin, typically right away as well. These are all crucial initial steps while you're mobilizing for reperfusion.
You also mentioned beta blockers are key long-term, but maybe not given immediately in all STEMIs.
Correct. While beta blockers are vital for secondary prevention after a STEMI, giving them acutely in the first few hours can be dangerous if the patient is unstable. If they have signs of heart failure, low blood pressure, shock, or severe bradycardia, you hold off on the beta blocker initially. You don't want to reduce contractility or heart rate when the heart is already struggling that badly. Stabilize first, then add the beta blocker later.
Makes sense. Okay, that covers the main ACS spectrum. But sometimes heart attacks don't follow the script, do they? Let's talk about these silent crises, atypical ACS presentations.
Yeah, this is a huge pitfall. So many diagnoses get missed or delayed because the patient doesn't have that classic crushing chest pain.
Who are the usual suspects for these atypical presentations?
Three main groups you have to be suspicious in: the elderly, women, and patients with diabetes, especially long-standing diabetes. Their nerve signaling can be different or blunted.
So what kind of symptoms do they get, these anginal equivalents?
Instead of chest pain, they might just have sudden, unexplained shortness of breath or overwhelming fatigue, nausea, vomiting. Sometimes it's epigastric pain like bad indigestion or heartburn right in the upper abdomen.
That seems dangerous, mistaking a heart attack for reflux.
Extremely dangerous. That's why the clinical imperative, the absolute rule, is in these high-risk patients presenting with these atypical symptoms, you must rule out ACS first. Get an ECG immediately. Start serial troponins. Don't just give them an antacid and send them home or down the GI workup path initially.
Even if the first ECG is normal.
Even then, if your suspicion is high based on the patient, their risk factors, and the story, you need serial ECGs and serial troponins over several hours. A single normal ECG doesn't rule out ACS, especially early on or in atypical cases. Think heart first.
Okay, really important point. Now let's dive into a really tricky scenario where the standard rules get flipped. The right ventricular myocardial infarction, RVMI.
Ah, yes, the RVMI. This usually happens along with an inferior wall STEMI. Why? Because the right coronary artery, the RCA, typically supplies both the inferior wall of the left ventricle and the right ventricle, so an RCA occlusion often takes out both territories.
And when the right ventricle infarcts, it fails to pump blood forward effectively, creating a very specific hemodynamic picture, the classic triad.
Exactly. The RV is thin-walled, very dependent on having enough blood volume coming back to it. It's preload dependent. When it fails, three things happen. One, hypotension. It can't pump blood forward to the left ventricle, so cardiac output drops, blood pressure falls.
Okay, low BP, what's two?
Two, jugular venous distension, JVD. Blood backs up from the failing RV into the right atrium, then back into the vena cava and the jugular vein. So you see those neck veins bulging.
Hypotension, JVD, and the third, crucial piece.
Clear lungs. This is key. Because the RV isn't pumping blood effectively into the pulmonary circulation, the lungs don't get congested. You don't hear crackles or see pulmonary edema on chest x-ray typically.
And that combination hypotension, JVD, but clear lungs sets up the management trap.
The biggest trap in acute cardiology, maybe, because normally if someone has a heart attack and low blood pressure, you might think about things like nitrates or morphine cautiously. But here, absolutely contraindicated. Because nitrates, morphine, and diuretics all reduce preload. They decrease the amount of blood returning to the heart. But the failing RV desperately needs that preload to stretch and generate any kind of forward flow. If you drop the preload, the RV just collapses functionally, the hypotension gets way worse, and the patient can spiral into irreversible shock.
So what do you do? It sounds counterintuitive for a heart attack patient.
You give fluids. Aggressive 5E fluid resuscitation is the first-line treatment for RVMI shock. You're trying to boost that preload, fill the tank, to help the stunned RV push enough blood forward to maintain cardiac output. It's one of the few times you're giving boluses of fluid to someone having an MI.
Wow. Knowing that pattern is literally life-saving. Okay, let's switch gears to toxins. Cocaine-induced ACS. What's the mechanism there?
It's a perfect storm caused by massive sympathetic nervous system overdrive. Cocaine blocks the reuptake of neurotransmitters like norepinephrine.
Flooding the system with adrenaline, basically.
Exactly. So you get intense tachycardia, severe hypertension, which dramatically increases the heart's oxygen demand. At the same time, cocaine causes potent coronary artery vasoconstriction, clamping down on the supply. And it also promotes platelet aggregation and thrombus formation. So demand skyrockets while supply plummets, and you get clot formation. Recipe for disaster.
So the first move isn't necessarily reperfusion, but calming that sympathetic storm.
That's right. The first-line treatment is IV benzodiazepines like lorazepam or diazepam. They calm the central nervous system, reduce the sympathetic outflow, help lower the heart rate and blood pressure, and can even help alleviate the coronary spasm. You still give aspirin, of course, and consider nitrates or calcium channel blockers for the spasm.
But there's a huge do not give medication here too, isn't there? Beta blockers.
Absolutely critical contraindication. Giving a beta blocker, especially a non-selective one, to someone with acute cocaine toxicity is extremely dangerous.
Why is that? Beta blockers are usually good for MIs.
Because cocaine stimulates both alpha and beta adrenergic receptors. Beta receptors, particularly beta-2, cause some vasodilation. Alpha receptors cause vasoconstriction. If you block the beta receptors, you leave the alpha receptors unopposed, meaning you get runaway alpha-mediated vasoconstriction, making the coronary artery spasm much, much worse. It can precipitate a massive infarction or cardiovascular collapse. So benzos first. Avoid beta blockers in the acute setting of cocaine use.
God, how does that compare to vasospastic angina or Prinzmetal angina? That's also spasm, but different cause.
Right. Prinzmetal is typically spontaneous coronary artery spasm. It often happens at rest, frequently in younger patients, sometimes smokers. The key is that the spasm causes transient ST elevation on the ECG during the pain episode.
Mimicking a STEMI.
It can, transiently. But then the spasm resolves, the pain goes away, and the ECG normalizes. And importantly, if you do an angiogram later, the coronary arteries themselves often look completely normal without fixed blockages. It's a problem of vascular hyperreactivity.
So the treatment focus is on preventing the spasms from happening.
Exactly. The first-line therapy for prevention is calcium channel blockers. Drugs like diltiazem or verapamil are very effective at relaxing the vascular smooth muscle and preventing spasm.
And things to avoid.
Similar to cocaine, you generally avoid non-selective beta blockers as they could theoretically worsen spasm. And interestingly, even high-dose aspirin is sometimes avoided in pure Prinzmetal, as prostaglandins might play a role. CCBs are the mainstay.
Okay, really useful distinctions there. Now, let's say the patient has survived the acute ACS event. The clot is busted or stented, the immediate fire is out. But the danger isn't over, right? We need to think about the aftermath, starting with cardiac remodeling.
Yes, this is crucial for long-term prognosis. After an MI, especially a large one, the heart starts to change structurally and functionally. This is cardiac remodeling.
What does that actually involve?
The dead heart muscle gets replaced by scar tissue, which doesn't contract. To compensate for the lost function, the remaining healthy heart muscle works harder. It can hypertrophy, get thicker, but also often dilates, stretches out, and the overall chamber gets bigger and weaker over time. It becomes less efficient.
And this isn't just a passive process, is it? The body's own systems drive it.
Absolutely. It's actively driven by neurohormonal activation. The body senses the drop in cardiac output and activates the renin-angiotensin-aldosterone system, RAAS, and the sympathetic nervous system, SNS. These systems raise blood pressure, retain salt and water.
Trying to help, but actually making things worse long term.
Exactly. That increased pressure and volume load puts more stress on the already damaged ventricle, accelerating the dilation and thinning, leading progressively towards heart failure.
So the core strategy to prevent this downward spiral is blocking those systems. Neurohormonal blockade.
Precisely. This is where the long-term life-saving medications come in. The absolute cornerstone is an ACE inhibitor like lisinopril or an ARB like losartan. If they can't tolerate an ACE inhibitor, these directly block the RAS system.
And they're especially important if the heart function is already reduced.
Definitely. They are strongly indicated, essential really, if the left ventricular ejection fraction, the LVEF, a measure of pumping strength, is 40% or less after the MI. But they generally benefit almost everyone post-MI.
Who else is in the cocktail?
Beta blockers are the second pillar. Started once the patient is stable, they block the sympathetic nervous system's effects on the heart, slowing heart rate, reducing workload, and preventing arrhythmias. They also have anti-remodeling effects.
And a third class sometimes, aldosterone antagonists.
Yes. Drugs like spironolactone or eplerenone. These provide additional RAAS blockade further down the pathway. They're typically added if the LVEF remains 40% or less despite ACE inhibitors and beta blockers, or if the patient also has diabetes. These three classes, ACE, IARB, beta blocker, and sometimes aldosterone antagonist, are the key anti-remodeling drugs.
It's really important to contrast these with the other drugs we talked about. Aspirin, P2Y12s, nitrates. They don't stop remodeling, do they?
No, they don't. Aspirin and P2Y12 inhibitors prevent clots. Nitrates help with symptoms. But they don't fundamentally alter that long-term structural breakdown of the heart muscle. The ACE inhibitors, beta blockers, and aldosterone antagonists are the ones proven to reduce mortality and prevent heart failure progression by tackling remodeling head-on.
Okay. Now, moving further down the timeline, Months after a big MI, sometimes a specific structural problem develops, a left ventricular aneurysm.
Right, this is a late complication. We're talking typically months after a large transmural MI1 that went through the full thickness of the wall. That scar tissue, instead of just being stiff, can actually stretch and thin out over time, forming a bulge and outpouching on the LV wall.
A non-contractile bulge.
Exactly. It doesn't pump, it just kind of passively fills with blood. And there's a very specific ECG finding that hints at this.
Which is?
Persistent ST segment elevation in the leads corresponding to the area of the old MI long after the acute event. Months later, those ST segments are still up, often along with deep Q waves from the original infarct. The ECG never fully normalized. That persistence is the hallmark of an aneurysm.
And what are the dangers of having this aneurysm? It's not just poor pumping, is it?
No, it causes a triad of problems. One, obviously heart failure, because that segment isn't contributing to pumping. Two, ventricular arrhythmias, like ventricular tachycardia, VTAC. The border zone between the scar tissue and healthy muscle can be electrically unstable, setting up circuits for dangerous rhythms.
And the third risk?
Systemic embolization. Because blood can become stagnant inside that non-moving bulge, a blood clot called a mural thrombus can form on the wall inside the aneurysm. If pieces of that clot break off, they can travel through the circulation and cause a stroke or block an artery in a limb.
Okay, that's a serious late mechanical issue. Let's talk about a different kind of late issue, an inflammatory one. Post-cardiac injury syndrome, also known as Dressler syndrome.
Dressler's is interesting. It's basically an autoimmune pericarditis that happens typically weeks to months after some kind of injury to the heart muscle or a pericardium like an MI or cardiac surgery or even trauma.
The body reacting to its own damaged tissue.
Essentially, yes. The immune system gets sensitized to cardiac antigens released during the initial injury and then mounts an inflammatory response against the pericardium later on.
And clinically, it presents like typical pericarditis.
Very much so. The key symptom is pleuritic chest pain, sharp, worse with breathing in, often relieved by sitting up and leaning forward. Patients might also have a fever. And the ECG typically shows diffuse ST elevation across many leads, sometimes with PR segment depression, which are classic signs of pericardial inflammation.
How do you treat this, especially given the patient likely just had an MI and might be on blood thinners?
Treatment is focused on the inflammation. High-dose aspirin is often the preferred anti-inflammatory in the post-MI setting, as it doesn't interfere with the necessary antiplatelet therapy as much as other NSAIDs might. Colchicine is also frequently added to treat the acute episode and prevent recurrence.
And the critical warning here relates to anticoagulation.
Yes, absolutely crucial. If someone has active Dressler syndrome, active pericarditis, therapeutic anticoagulation, like the heparin used acutely for MI or warfarinoates long-term, is generally contraindicated. The inflamed pericardium is leaky, and anticoagulation significantly increases the risk of bleeding into the pericardial sac, causing a hemorrhagic effusion and potentially cardiac tamponade. You have to treat the inflammation first.
Makes sense. So, pulling this section together, what's the standard, essential, long-term medication package, the secondary prevention regimen that virtually everyone needs after an MI?
Okay, the post-MI cocktail, non-negotiable for most people. First, dual antiplatelet therapy. DAPT, that's aspirin, usually lifelong, plus a P2Y12 inhibitor, clopidogrel, ticagrelor, or prasugrel, for at least 12 months, especially if they received a stent.
DAPT for a year. What else?
Second, a beta blocker. Third, an ACE inhibitor, or ARB. And fourth, a high-intensity statin. Those four pillars, DAPT, beta blocker, ACE-IRB, statin, are foundational for secondary prevention, reducing risk of another event, preventing remodeling, and improving survival.
Got it. Okay, let's move into some of the more dramatic, acute complications, things that happen mechanically or related to procedures. First, these early mechanical complications, usually within days of the MI.
Right. This is when the infarcted tissue is still soft and necrotic before significant scarring has occurred. The first few days are a vulnerable period. One major disaster is papillary muscle rupture.
Which muscle usually ruptures and why?
It's most often the posteromedial papillary muscle. Its blood supply is often tenuous, frequently coming solely from a branch of the right coronary artery, RCA, or the circumflex. So an inferior or posterior MI that takes out that vessel can cause the muscle to infarct and rupture. This usually happens around 3 to 5 days post-MI.
And the papillary muscles hold the mitral valve leaflet, so if one ruptures...
Catastrophe. You get acute, severe mitral regurgitation. The valve suddenly becomes incompetent, massive amounts of blood flow backward into the left atrium with each beat. This causes sudden onset pulmonary edema, flash pulmonary edema, and cardiogenic shock. Clinically, you hear a loud, new systolic murmur.
And the treatment.
Surgical emergency. Urgent cardiac surgery to repair or replace the mitral valve is the only definitive treatment. Medical stabilization is just a bridge.
Okay, that's papillary muscle rupture, 3 to 5 days. What's the other major mechanical rupture in that early time frame?
The other big one is left ventricular free wall rupture. This tends to happen a little later, maybe 5 days to 2 weeks post-MI, often after a large anterior MI where the wall has thinned significantly.
And this is the actual outer wall of the ventricle tearing.
Yes. The necrotic muscle gives way, and blood bursts out of the ventricle directly into the pericardial sac surrounding the heart.
Leading to?
Rapid cardiac tamponade. The pericardial sac fills with blood under pressure, compressing the heart chamber so they can't fill. The patient suddenly crashes, profound shock, and very often presents in PEA, pulseless electrical activity. The heart has electrical rhythm, but no effective output because it's being squeezed.
Prognosis is grim here.
Extremely grim. It requires emergency pericardiocentesis, draining the blood from the sac immediately, followed by emergent surgery to attempt repair of the rupture. Survival rates are unfortunately low.
Okay, terrifying complications. Let's shift from MI complications to post-surgical ones. After bypass surgery, CABG, what's the feared deep infection?
Mediastinitis. This is a deep sternal wound infection involving the bone and the tissues in the mediastinum under the sternum. It's serious, mortality can be high, 20–40% even.
What are the signs and symptoms to watch for?
Fever, tachycardia, chest pain, sometimes purulent drainage from the sternal incision. But a really specific and ominous sign is sternal instability if the patient feels or hears a click in their chest, or if you can physically rock the sternum when you palpate it. That suggests the bone hasn't healed properly, often due to underlying infection.
So if you suspect mediastinitis, maybe the patient has a lot of drainage but isn't febrile yet, what's the crucial first step? You don't just start antibiotics, right?
No, you absolutely need imaging first, usually a CT scan of the chest. You have to assess the extent of the infection. Are there fluid collections, abscesses? Is the bone involved, osteomyelitis? Because the management depends heavily on the depth.
And if the CT confirms deep infection?
Then it's another surgical emergency, essentially. Prompt surgical debridement is required. They need to open the wound, wash out all the infected material, remove dead tissue. That's followed by long courses of broad-spectrum IV antibiotics. Antibiotics alone will not cure established mediastinitis.
Good point. We should contrast that with something common and usually benign after CABG.
Right. Small pleural effusions, especially on the left side, are very common after cardiac surgery. Usually they're small, resolve on their own, and just need observation unless they become very large, are rapidly accumulating, or causing breathing problems. Don't jump to conclusions about infection just because there's a small effusion.
Okay, let's turn to complications from the cardiac catheterization procedure itself, particularly when using the femoral artery approach in the groin. What about bleeding after the procedure?
A major concern is retroperitoneal hematoma. This is bleeding from the femoral artery puncture site, but instead of coming out, the blood tracks backwards internally into the large retroperitoneal space behind the abdomen.
And because that space is big, you can lose a lot of blood quickly.
A lot of blood, yeah, leading to hypovolemic shock. This usually happens within the first 12 hours after the procedure. The classic signs are sudden, unexplained hypotension, tachycardia, and often ipsilateral flank or back pain as the hematoma expands.
You mentioned a key physical exam finding earlier that helps distinguish this from, say, tamponade.
Yes, the neck veins. In retroperitoneal hemorrhage, the patient is losing volume, so their neck veins will be flat. In tamponade, the heart is being squeezed, so backup causes distended neck veins, JVD. Flat neck veins plus shock plus flank pain after femoral access, think retroperitoneal bleed.
Diagnosis confirmed how?
CT scan of the abdomen and pelvis, usually with contrast, will show the hematoma. Management involves fluids, blood transfusion, and sometimes intervention to stop the bleeding.
What if, at the puncture site itself, you hear a continuous sound, like a whoosh?
A continuous bruit, especially if you can also feel a thrill, a vibration, suggests an arteriovenous AV fistula. This means the needle likely punctured both the femoral artery and the adjacent femoral vein, creating an abnormal connection between them.
So high-pressure arterial blood is constantly flowing into the low-pressure vein.
Exactly. That continuous flow generates the continuous bruit and thrill. This needs to be differentiated from a pseudoaneurysm.
How does a pseudoaneurysm present?
A pseudoaneurysm is basically a contained hematoma, a collection of blood, outside the artery wall that's still connected to the artery lumen through the hole in the wall. It pulsates with the artery. Clinically, it usually presents as a tender, pulsatile mass at the puncture site, and importantly, the bruit is typically systolic only, not continuous, because blood only squirts into the sac during systole.
Okay, AD fistula is continuous bruit. Pseudoaneurysm is systolic bruit.
Yeah,
Now, what about the stent itself clotting off?
the stent thrombosis. Yeah, this is a devastating complication. It's essentially an acute MI, usually a STEMI, caused by a sudden clot forming inside the recently placed stent. It most often occurs relatively early, within the first 30 days after PCI, but can happen later too.
And the number one reason this happens?
By far, the most common cause is non-adherence to dual antiplatelet therapy. The patient stops taking their aspirin, or more often, their P2Y12 inhibitor, clopidogrel, ticagrelor, prasugrel, too soon. That stent is a foreign body, highly thromogenic initially, and needs those potent antiplatelet drugs to prevent clotting until the artery wall heals over it. Stopping DFPT prematurely is playing with fire.
A really crucial message for patients. Okay, one last, somewhat bizarre procedural complication. Cholesterol embolism or atheroembolism?
Yes. This is different because it's often delayed, happening days to even weeks after a procedure involving catheter manipulation in the aorta, like cardiac cath or aortic surgery.
What's actually happening?
During the procedure, the catheter or wires can scrape against atherosclerotic plaque on the inside of the aorta, dislodging showers of tiny cholesterol crystals and debris. These then travel downstream in the blood.
And lodge where?
They lodge in the smallest arterioles throughout the body, the microcirculation. This causes inflammation and obstruction in various organs.
Is there a classic clinical picture for this?
There is a classic triad often described. 1, acute kidney injury, AKI, as the crystals lodge in the renal arterioles. 2, levato reticularis, which is a mottled purplish net-like rash on the skin, especially the lower extremities, due to occlusion of dermal arterioles.
And the third part, the toes.
3, blue toe syndrome. The toes might look cyanotic or even gangrenous due to microvascular occlusion. But here's a key diagnostic clue. The larger, palpable distal pulses, like the dorsalis pedis or posterior tibial, are usually still present and feel normal because the large arteries aren't blocked, only the tiny ones. That combination, ischemic-looking toes with palpable pulses, strongly suggests atheroemboly.
And confirmation.
Definitive diagnosis can sometimes be made by biopsy of an affected organ, like skin or kidney, which shows the characteristic needle-shaped cholesterol clefts within the small vessels. Management is mostly supportive, unfortunately.
Fascinating, complex stuff. Okay, let's wrap up with risk stratification and prevention for the future. First, assessing cardiac risk before someone has non-cardiac surgery. The RCRI score.
Right, the Revised Cardiac Risk Index. It's important to remember this is specifically for predicting major cardiac complications, like MI or cardiac arrest, around the time of non-cardiac surgery. It doesn't use all the traditional CAD risk factors.
What doesn't it use?
Things like controlled hypertension, high cholesterol, smoking history, family history. Those are long-term risks, but don't strongly predict acute perioperative events, so they're not in the index.
So what is in the RCRI? What are the 6 factors, each worth 1 point?
Okay, the 6 points are: 1, high-risk type of surgery. Examples: major vascular surgery, intraperitoneal or intrathoracic surgery. 2, history of ischemic heart disease, prior MI or positive stress test. 3, history of congestive heart failure. 4, history of cerebrovascular disease, stroke or TIA. 5, insulin-dependent diabetes mellitus. And 6, preoperative serum creatinine greater than 2 milligl, indicating significant kidney disease.
So you add up the points, 0 to 6. How does the score guide management? Do high scores always mean more testing?
Not necessarily. If the score is low, 0 or 1 point, the risk is very low, and the patient usually proceeds to surgery without further cardiac workup. If the score is 2 or higher, indicating elevated risk, the next question is about their functional capacity.
How well can they handle physical activity?
Yeah.
Measured in METs.
Exactly. Metabolic equivalents, or METs. Can they climb 2 flights of stairs or walk 4 blocks without stopping, which is about 4 METs. If a patient with an RCRI score of 2 or more has good functional capacity, more than 4 METs, they generally don't need further testing like a stress test before surgery. The idea is, if their heart can handle reasonable daily activity, it can likely handle the stress of surgery, even with known risk factors.
But if their functional capacity is poor or unknown and they have an elevated RCRI score?
Then you consider further non-invasive testing, like a stress test or perhaps echocardiogram, to better define their risk and guide potential interventions before the non-cardiac surgery.
Okay, that's preoperative risk. Now, finally, let's circle back to primary prevention, stopping that first heart attack or stroke from ever happening. Statins are key here too, right? Who needs a high-intensity statin for primary prevention?
Right. Based on current guidelines, there are several groups who should be on high-intensity statins even if they've never had an event. First, anyone with a very high LDL cholesterol level, specifically LDL 190 milligdl. That often suggests familial hypercholesterolemia.
Okay, LDL 190. Who else?
Second, almost all patients aged 40 to 75 with diabetes mellitus. Diabetes is considered such a potent risk equivalent that statin therapy is recommended broadly in this group.
Makes sense. And the third group is based on calculated risk.
Yes. Using the ASCVD pooled cohort equations risk calculator, if someone aged 40-75 has an estimated 10-year risk of having an atherosclerotic cardiovascular event that's 7.5% to 10% or higher, they generally warrant initiation of at least a moderate intensity and often a high-intensity statin. There's some nuance and discussion with the patient involved there, especially in the 7.5–20% risk range.
And what about using aspirin for primary prevention? That recommendation has changed quite a bit, hasn't it?
Dramatically. The pendulum has swung away from routine low-dose aspirin for primary prevention, especially in younger adults. For most people under 50, and even many older adults without known cardiovascular disease, the risk of bleeding complications from aspirin, like GI bleeds or hemorrhagic stroke, now appears to outweigh the modest benefit in preventing a first MI or stroke.
So it's not a standard recommendation anymore for most people just trying to stay healthy.
No, definitely not routinely recommended for primary prevention in lower risk individuals, particularly those under 60, and used very cautiously, if at all, based on individualized risk assessment in older adults. It's really shifted towards being primarily a secondary prevention drug, or for very specific, high-risk primary prevention scenarios after careful discussion.
And just to reiterate why statins remain so central compared to other things people might take for cholesterol like niacin or fish oil.
It comes down to the outcomes data. Statins, particularly high-intensity statins, are essentially the only class of lipid-lowering medication that has consistently and robustly demonstrated a significant mortality benefit in large-scale clinical trials across diverse populations. They don't just improve lab numbers, they save lives. Other agents like niacin, fibrates, fish oil, they might move the lipids around, but they haven't shown that same definitive impact on reducing death rates. That's why statins are foundational.
A powerful reminder. Wow, okay. This has been an incredibly dense, really high-yield deep dive. We've gone from, the microscopic level of plaque stabilization right up to the critical minute-by-minute decisions in the emergency department and cath lab.
It really highlights the need for precision, doesn't it? Thinking about how just looking at the neck veins and listening to the lungs tells you whether to give fluids or diuretics in RVMI, that difference can be life or death.
Absolutely. And understanding the timeline, knowing that papillary muscle rupture is a risk at 3 to 5 days, while an LV aneurysm is months down the road, completely changes how you monitor and manage the patient long term.
Right. Knowing that sticking to diapity for the full year drastically cuts the risk of stent thrombosis, or that starting an ACE inhibitor early helps prevent that detrimental remodeling over months and years. It's all linked.
Which leads to a final thought, perhaps.
Yeah.
If we know these timelines, and we know that choices made in the acute phase, like PCI versus lysis for a STEMI, might influence the degree of scarring and subsequent remodeling.
Yeah, you start to wonder, how much further can we refine this? Could future risk models, maybe using AI or more personalized data, actually predict not just if a patient might develop heart failure or an aneurysm after their MI, but integrate the specifics of their acute treatment to predict when those complications are most likely to arise for that specific individual?
Moving beyond general risk to a personalized chronology of potential failure. That's definitely something to think about. A fascinating frontier. Well, this has been incredibly informative. Thank you for walking us through it.
My pleasure. It's complex, but hopefully this helps bring some clarity.
I'm sure it will. Thank you all for joining us on the deep dive. We'll catch you next time.